Chair, dear colleagues. Yes, I'm working mainly and focusing mainly on the microbiome, but during my PhD years, I'm exploring the possible options to optimize care for the critically ill. My name is Dilan, Márk, Karim, and I work here at the university at the Anesthesiology and Intensive Care Department. And my vision is, let's say, that science may overcome quackery at one day. And for that mission nowadays, I'm trying to understand better and then disseminate better the beauty and the pitfalls of evidence creation. To investigate microbiome and dysbiosis in the critically ill, we are conducting a meta-analysis, and we are planning an RCT on a possible preventive measure of alcohol withdrawal syndrome in the critically ill. So in the first project, we are investigating the extent of dysbiosis, which is a great problem. Dysbiosis, the serious disruption of the microbiota in the gut or in other body parts, may lead to the overgrowth of pathogenic bacteria, and that may lead to secondary infections possibly. The critical illness, the severity of the illness, and the specific interventions that we are applying on our patients to help them may lead to dysbiosis. And we already know that this may affect mortality and morbidity significantly. So measures to counteract this steep rise in mortality and morbidity have been tested, but resulted not clear evidence yet. And we still don't know the incidence and the real impact on outcomes of dysbiosis. So our aim is to analyze the relationship between different clinical scenarios, illness states, severities, and clinical outcomes and dysbiosis. We are focusing to answer what is the extent and the risk factors for dysbiosis. For that, we are collecting diversity indices, which we think can describe well the state of dysbiosis in our patients, and we are examining the relationship between different exposure factors like illness severity, interventions applied, and the illness-associated conditions. And our hypothesis is that it's frequent and it's influenced by several illness-associated conditions. And we think that increasing awareness on the topic may lead to appropriate testing and possibly implementation of preventive measures in the critically ill. I conducted the systematic research in the three main databases very recently. And with the final search key, we are focusing on two main domains to have it very wide. We are collecting all papers regarding to critically ill patients, and we are collecting all papers that assessing microbial diversity. With that very wide search strategy, a huge pool of records have been collected. And after duplicate removal and preliminary abstract title selection, over 700 papers are there for us for full text selection. To investigate the potentials of ethanol substitution for prevention of alcohol withdrawal syndrome, we are planning a randomized controlled trial. This alcohol withdrawal syndrome is a very serious complication, a very serious problem. It's potentially life-threatening. It appears in 1/4, 1/5 of the cases of abrupt discontinuation of chronic ethanol use. And it comes with a steep rise in mortality due to cardiovascular and metabolic complications. There are a huge variety of complications that can appear. They are collected in this word cloud. There are serious ones and less serious ones, but they are very damaging. And we already know the criteria to identify patients at risk. We also know that critical illness and alcoholism come with a steep rise in mortality. And we also know very much that treating delirium is very long and very painful. As the author of a Cochrane review article stated, most pharmacological interventions are not more effective than placebo. for treating critically ill adults with delirium. So avoiding delirium is essential during this critical state. However, most of current evidence is only for treatment, and there is really no quality evidence on substitution with ethanol for prevention. But guidelines still recommend against ethanol for prevention, and they are not considering this vulnerable case of critical illness. So my aim is to gain reliable evidence on the advantages, safety, and disadvantages of preventive alcohol substitution during this very acute phase of any serious disease. We are enrolling patients who are heavy drinkers, defined by strict criteria, admitted to the ICU of any cause. And in one blinded arm, we are substituting ethanol, and in another arm, patients getting placebo. And of course, if any withdrawal symptoms appear as a part of usual care, this so-called reactive alcohol withdrawal syndrome protocol appears to treat the patients. And we are collecting and measuring symptoms, severity of symptoms, delirium, depth of sedation. It's very interesting, the difference between the groups, and safety endpoints and mortality. Our hypothesis is that alcohol substitution is effective and safe to avoid serious complications. And of course, we think that reducing the incidence of the appearance of alcohol withdrawal syndrome in this very, very vulnerable state of patients can mitigate the severe complications and the related mortality. We still have issues to clarify, like dose ranges, safety and ethical concerns, measurement tools that must be used, and the route of administration, for example. And for those, after a preliminary search, I conducted a systematic search in the main databases, and I can tell you that really not so many papers are assessing the same topic. So we are in a good path. To facilitate research during intensive care, we are conducting this meta-analysis to understand the microbiome interaction better, and the possible preventive measure for alcohol withdrawal syndrome. That's my two topics now. And thank you for your kind attention. And if you have any questions, feel free.
First, I would like to congratulate you on your presentation. It was awesome. I would like to ask you if you would be able to elaborate on how you define a heavy drinker.
I had a whole slide of that. I will show you on next Friday or Wednesday. But here, down there, you can see that we are planning to use the DSM-4 criteria. There is also the WHO definition. And there is this, I think you might know, the Audit A survey, which is assessing the alcohol dependence, and it scales it. So with that, those were the ones majorly used in previous articles.
Thank you so much.
Thank you.
I also have a question for your second topic. So what kind of ethical and safety considerations are you thinking of?
In the last decades, somehow the research on alcohol substitution went to zero, and that's mainly because of ethical and safety issues. And interactions with drugs and those pharmacological issues are stated mostly, but most of the times there is a view, something can be phrased like this: this is the only chance for someone to get out of this serious disease of heavy drinking. This is the only chance of him while he's in the hospital to help him to be free of this burden of alcohol dependency. And that's somehow true. But we think that maybe helping the patient a bit later than the critical stage of his disease is a better approach.